Hm.
So welcome to everybody who's coming in. We're waiting another 2 minutes to give people a chance to come in before we start with this webinar. Okay, it's 2 minutes past 5. Numbers of people dialing in are stagnating, so I think it's a good time point to start now. I'd like to welcome everybody who's participating to this ENS spine section webinar, which is always on the first Wednesday in the month. We had so far different topics in spine surgery with very well-known speakers. And today, in continuation of this webinar, we have another very well-known speaker with Bernhard Meyer, who's chairman of the Department of Neurosurgery at the Technical University in Munich as a presenter. And he's a very well-known expert in many fields of spine surgery, of spinal diseases, spinal disease management. And tonight he's going to talk about a special topic which is coming up in the recent years and gaining more momentum and importance in the recent years, which is low-grade infections, low-grade implant-associated infections, and the diagnosis and management of these infections. I'm very happy to have you here, Bernhard. I'm looking forward to your presentation. We have the presentation. Afterwards, we have the discussion. So for everybody who's participating for the discussion, please use the Q&A box or the chat box, where I'll have a look at both boxes and to read out your questions afterwards. Okay, Bernhard, welcome. We're looking forward to your presentation.
Thank you very much, Florian, and good evening, everybody. I'm going to share my screen right now. I hope you can see that, I assume. So we're talking about low-grade infection and spinal instrumentation, something which we, actually, Florian and I and other co-workers were involved with now for almost 6 years. We've been aware of things that we haven't been aware of. And so I'm trying to make you aware of that. First of all, my disclosures, as you see, I have many. It's not really important for that talk, just to let you know. I always start with that case because it signifies a couple of things. This was a lady that was operated for a metastasis of C2 in a clinic elsewhere a couple of years ago now. And this is the way she was operated: dorsal stabilization, and then there was an embolization procedure, and it was radiated, and actually it went well for a very long time. And then she had this MR, and then 4 or 5 years later, she came with that, which is, you can see it's an instrumentation failure. That was the MR at that time. That was the CT at that time. So the surgeon saw that there was screw loosenings, and then he said, yeah, we need to do revision, and we have to do another type of surgery, which he did. So he did a revision surgery, going farther down, placing new lateral mass screws with a decent reconstruction. But that only took about a couple of months till it failed again, and that was the MR, which he presented then at my department, and that's then the lateral X-rays and the CT at presentation here. I just want to make you aware of this slide. If you look at these things, I want you to remember that picture. So I thought, in contrast to probably many other people, that there is, at least for me, a high index of suspicion that this is a low-grade associated screw loosening or implant failure. So what I talked to this patient was that we would take away the posterior implants, tonicate them, give IV antibiotics for 2 weeks, and then we will do obviously a reconstruction anteriorly and continuous IV antibiotics. And then after that, we'll have a revision surgery from the back, which we then did. This is the final construct. And indeed, in these screws, you could find propionibacteria, and being clear that this was a low-grade infection associated and not only a biomechanical failure. So this teaches you that propionibacteria, which is actually known to be or Staph epidermidis being the commensal that is associated with biofilm, which other people like orthopedic surgeons who do knee and hip implants know for a very long time, is not really in our awareness or in the awareness of a neurosurgeon or of spine surgeons. But just one take home before, if you see a CT picture of that with an implant failure, with a large halo around that, this is almost pathognomonic for not a biomechanical failure, but for a failure which is associated with this type of biofilm. So bacteria that produce biofilms are better protected from your immune system, and they are a lot more resistant to antibiotics or biocides than your regular inflammatory agents that you will see. And these are the 4 or 5 stages of biofilm formation. And if you do a revision surgery, what you usually see, you see these slimy things around the bone or the pilot holes or your screws. And once this biofilm is formed and has a stage 4 or 5, it's immune to IV antibiotics in itself without having a revision. That means a debridement in addition to that. Ever since 2007, when in the New England Journal of Medicine, the significance of sonication was established. At that time, obviously for prosthetic joint infections, orthopedic ones, that was authored by André Trampusch. Everybody, at least in the orthopedic community, knew how to deal with that type of infection, because there's one key feature. You don't detect these infections because they are not real infections. They're actually just localized biofilm producing things. If you don't adhere to the standard how to diagnose this, number one is your implants need to be put in a sonication fluid, and this in a sonication bath with ultrasound, and from that fluid cultures should be taken and must be taken, and the culture should be 14 days. Only if after 14 days the sonication fluid is sterile, then there is no biofilm visible, and this is not related to a low-grade infection. But this is the 2 things that need to be done to rule out definitely this type of low-grade infection. And it started then coming into the focus. This is the first publication on it, actually not old, in the retrospective study. Then in 2018, there is another retrospective study that shows that when they explanted their material in 110 cases, they could see that in 1/3 of the cases, they found bacteria. Obviously, there were flaws to that study, with like with every other retrospective study. So That is the first prospective study in the year 2019 from Berlin, and they compared patients with a control group, and they had results that roughly 40% in the screw loosening group had a positive sonication result. That means that at least in 40% of their patients, a low-grade infection was associated with the screw loosening. We then had basically simultaneously, and that was also almost simultaneously published a half year later in 2020. Also a publication that is out in neurosurgery, and almost similar results, namely that in 42% of the group that has screw loosening, we had positive cultures. But on the other hand, and this is one of the riddles, even in the comparison group, I show you the group then later on, almost 18% had a positive culture. So that means that you have these germs, and this is known in your body, and most people can cope with it, and some people can't. And this is one of the questions where we don't have an answer yet why this is the case. So I just lead you through the study. We had 101 patients who needed revision surgery for their metal implants in the spine, usually the lumbar or thoracic spine. And of these 101 patients, 63 had a visible screw loosening and 38 not. These 38 were the control group, and they had no visible screw loosening and were revised because they had adjacent segment disease. So they needed an inclusion of another segment in a formerly fused segment. So this is the study group where you could see these pathognomonic pictures. And this is the control group, which had solid arthrodesis, no screw loosening, but as you see here, adjacent segment disease. And the primary outcome was the rate of low-grade infections detected in the sonication fluid of the implants. These are the demographic data of these patients. The study group was a bit younger than the comparison. There was a higher incidence of diabetes. I'm unsure whether this has anything to do with it, but this is one factor. And obviously, on average, these patients were revised almost a year later or 10 months later, as opposed to the adjacent segment group, which is several years later. But this is, I think, quite obvious. This is something I also want to keep you in mind. As opposed to an infection as you know it, which is a putrid infection immediately for several days or some weeks after surgery with known germs like Staph aureus or something like that, where you have a generalized infection, which is visible also in the bloodstream. A low-grade infection, the hallmark is it's a localized infection, actually only a biofilm formation, so you cannot detect it in the bloodstream. That means your leukocytes, as well as your CRP or any other inflammation marker, is not elevated. So this is the next thing you should keep in mind. And then you see, we found the usual suspects of mostly propionii or staph epidermidis, and maybe some others. So my first take-home message is that roughly half of your symptomatic screw loosenings that you will see are associated with a low-grade infection, and it is still underestimated up today. And what you need is then, and this is what you should take home, you have to have a high index of suspicion this might be the cause. And because your regular clinical and lab signs are inconclusive, they will be normal, as I just showed you. So I think whenever you have a patient with the screw loosening, you should do a sonication and a 14-day culture just to be on the safe side. And to take this just a little bit further, that it is an underestimated problem, I show you 3 other cases with in this type, in this case, and a different type of implant. This is an annular closure device. We published that in Acta Neurochirurgical. So this is 4 years after implantation of that, and then the patient developed significant back pain, and you see also a very, very specific CT here down there. You have these holes in the vertebral body, and this lucency around the implant. We just removed that. Sonication came back with propione. Immediately after removal, without stabilization, the patient was pain-free, and we gave him 14 days of IV antibiotics and then 4 weeks orally. This is a patient who didn't have any instrumentation, but simply a lumbar discectomy here, and developed over several months, I think 11 months, this type of thing, which is, again, and I want you to remember that pathognomonic for a low-grade infection. These bacteria are also in healthy disc, but also in healthy bone dust. So you can have them anywhere. So it doesn't need to be taken from the skin in there. And this patient then came to me, and we did obviously a revision surgery with instrumented stabilization, debridement anteriorly, etc., etc. The next case is even one step further. This patient had incredible back pain for 13 months, was never operated, nothing at all, and came to me with that picture. And most people think that this was schmaltz or whatever. So we took a biopsy out of that, and after 5 days, it CT guided, it came back as a low-grade infection with propione, without having any surgery or anything at all. And this patient underwent the same procedure, fixation from posterior and anterior reconstruction and debridement of that. So, but there are 2 questions which are somewhat unclear. The first is, how do you manage a patient like that, where you see now that you have a construct failure? You can see that for us, and I hope you have learned that this is pathognomonic, that there might be an associated low-grade infection. And obviously, the next question would be, how do you prevent that? Now, how to manage? There is no accepted guideline how to do that. I mean, that patients like the one I just showed you need a revision is obvious to everybody. How to do that is, however, an expert opinion. So these are 2 publications, one from Mayo Spine. This is a review down there, looking at all things that can be done with management of surgical site infection. That includes also acute infections, but there is a subchapter on low-grade infections. This is in German, but has an abstract in English, where some guidelines how to do that were prepared by the authors, but I just admit that there is no compelling evidence what is right or what may be the correct way to do so. And it boils down to the question, actually, do you do a 1-stage or a 2-stage revision? So if you have a patient like that, where you have a high suspicion that failure of arthrodesis, she was actually revised and then had a second failure immediately afterwards and sent to me, similar like the first case that I showed you, this type on the lumbar spine. The question is, do we take out at least the screws and then give antibiotics and then do a staged reimplantation? And just to tell you beforehand, this is actually my preferred way to do so, for several reasons. This is another patient with an obvious, you see that in S1, the screw loosening with the halo around it, where it's quite clear that, and also up here, which is quite clear that there's a high index or a high suspicion of being associated with a low grade, and was revised. The surgeon was even aware that this might be low grade, this is the revision surgery. You see immediately afterwards, oops, sorry. But then only 6 weeks later, you see again screw loosenings, and not only in the former S1, but also in the one in S2. And I have seen this very often. I can't argue that it never works, but this leads or has led to the fact that I give you as my take-home message number 2, that I would favor a 2-stage reimplantation, and it is considered state-of-the-art, at least by us. We do an implant removal and then debridement, local antibiotics, IV antibiotics for at least 2 weeks. We do a reimplantation either then or later on, let's say after another 4 weeks of oral antibiotics, which is actually my preferred way to do it. Delay as long as you can. Now, the much more difficult question, how to prevent, that is actually obviously related to the etiology of implant loosening. So if you see an implant loosening, it might be a simple mechanical overload. But as I told you, that among those where we always thought it's just mechanical, 40 to 50% are associated with a biofilm. Then some people think that mechanical overload leads to a dead space, and in this dead space, you can have a low-grade infection. I don't know if this is true, but obviously a mechanical component adds to any type of implant failure. So you should always try to adhere to the standards of biomechanics if you do a reimplantation. Nevertheless, I think how we don't know why some people develop that biofilm around their implants and other not. So there are 2 ways, and maybe it can happen in both ways. There might be a contamination during surgery, then you get the low-grade infection, the loosening. Or the alternative is that the bacteria are already in the patient. That means in the bone, and the patient, because it's a host factor, can cope with that, and then the biofilm is formed. It is unclear. Me personally, I think both ways are possible. The problem is that your regular disinfectant does not help you with decontamination of this type of commensal. Plus, you can even change your pre-op antibiotics to that which are specific to, for example, propione, and this does not affect the incidence. These are 2 things that are already shown. And we then were trying to shed a bit light on that, and this is a big project which is underway, and we don't have the results yet, where we combine more or less diagnostics with prevention in a very structured way to find out how many people do have this in their bone dust, and how many of these people develop a screw loosening, and why is that so. And hopefully in 2 or 3 years, we know more about this. For the time being, it's a bit frustrating, and I can't give you an answer to that. To all the other questions, I was trying to give you, with the best of my knowledge, what I think is correct. So thank you very much, and I will think that I will discontinue now my screen sharing so we can go to the discussion, Florian.
Yes, thank you very much, Bernard, for this excellent presentation. I think this is a very important topic, showing that screw loosening is not in all cases only a mechanical problem from poor bone quality or inadequate bone quality to implants, and not only a problem of sagittal alignment, but that there is a infection aspect in about 50% of cases, as you showed nicely. Now, for everybody who's participating, when you have a question, please use the Q&A box or the chat box, and I will have a look at the questions and read out those questions. But there's one I'd like to ask. Start with the first question. Now, you mentioned that you usually go for a two-stage revision surgery if you have screw loosening. But initially, if you have a loose screw, you don't know whether this is one of those 50% infected, low-grade infected or not. So would you go in the first step for the diagnostic procedure, removing those loose screws? Or would you, if you have, like the example you showed where you had at the upper end of the instrumentation and the lower end of the instrumentation, if you have loose screws, go for the explantation as a first step, then wait for your microbiological diagnosis and then treat? Or would you explant the loose screws only, do your diagnostics, and then either replace them or go for explantation of the rest of the instrumentation?
I always explant, always. I would say 95% I explant everything, yeah. And then wait for it. According to me, it doesn't make sense to leave the rest in. There are no major instability issues. These patients are all overall operated, but most of these patients, and this is where it happens usually, for degenerative instabilities. So there is no problem of immediate instability that will cause harm. At least it has never caused harm in any of my patients. We have now experience of, I think, 7 years of doing so, or even more. And this is the cleaner thing to do, according to me. Mm. So yes, I would always explant everything. And then after 14 days, there is the decisive moment where I know, okay, I would go for reimplantation right away because I didn't find any bacteria. Or if I found, I'm trying to postpone this even longer, 4 more weeks, 6 more weeks, etc. So this is the way I do it. But as I said, I just have, from my own perspective, a bad feeling of going in too early, because if you look at the sites, if you open these, you don't see pus as you do in an acute infection. But what you see all over the place is a slimy membrane, and you need to take this all out. Otherwise, you have a problem. We do with jet lavage, as you know, and you name it, just to get rid of everything that we have. And then I would say you need local antibiotics, which is usually vancomycin, put in, and then at least 14 days of IV.
If for those, if going for a single stage revision, would you then, I assume, change all instrumentation, even the ones which are not loose?
Yes.
Yeah, that's what we currently do, and there's always this ongoing discussion whether only the loose screws need to be changed. But I'm convinced that you should change everything, because there's already biofilm on the material, and you exactly just a question of time until you will get further screws and in the other adjacent levels. Okay, now we have some questions. There's one question: do you suspect a low-grade infection on a mechanical failure of a construct if you have loosening on the caudal and rostral part of your implants, especially if you don't have anterior support, example PJK or DJK? You already had one of those examples with the uppermost screw loose and the lowermost screw loose.
Yeah, but that was not a PJK. A PJK, per definition, is either a fracture of that upper level or a fracture above the upper level, if it's a proximal junctional kyphosis. There is the example I showed you, there was just a screw loosening without a fracture, with a halo around the screw, and the same was true for the S1, the lowest screw. It is very obvious that S1 screws have a lot of mechanical failures, especially in a long construct like that. So, as I said, these things are usually multifactorial. You need to have a mechanical, or you don't need to have, but you might have a mechanical component, but that does not tell you that you don't have a low-grade infection. So, and obviously, as it was, the surgeon did try to revise it and excluded the S1 screws and did S2 iliolars screws. So it was doing it. Yes, I suspect a low-grade infection in all cases. With my experience now, I more in one than in the other case, but what I will always do, I send in the implants for sonication.
Okay. So there's another question regarding mechanical problem to infection. It's about pseudoarthrosis in cage subsidence versus low-grade infection. How often do you have negative probes in low-grade infection suspected patient? I think related to interbody devices or any subsided cages or halos around cages. Or what's the role of the anterior instrumentation? We seem to be more reluctant to go to the anterior instrumentation, as posterior, to change posterior is much easier. And in my feeling, the anterior is not as much as a problem as the posterior instrumentation.
Well, if I don't, well, that depends on several factors. First, the picture. If I see a halo around the anterior construct, piece of cage or whatever, then I would suspect this is also a low-grade infection or biofilm around it, especially if it's a peak cage. And then I would say, yeah, there's a high index of suspicion that there is, and then you would need to revise that too, according to me. You don't have to do it in the same setting as the posterior construct. So sometimes I just leave the cage in, and then I would do the posterior re-instrumentation after you had your antibiotics, and then do a stage procedure, turn the patient and do an anterior reconstruction of the anterior space.
Okay. Then we have the question regarding material. Are there any material differences? And especially the question goes to carbon fiber reinforced PEEK screws or cages. Does it have an influence on the development of low-grade infections?
Actually, no. We have a very long experience with carbon PEEK screws, which we use basically only in oncological patients. But there are 500 patients, and on the average they have 8 screws, so you can do your math how many screws we see. And we have made a matched pair control also with the same patients who have a metal implant. There's no difference for the carbon screws with respect to low-grade infections.
Okay.
But there's a problem with carbon screws if you use them for acute infections. That means for spondylolisthesis. There we do see more problems with screw loosening, but in all the other indications not.
What about screws which are impregnated with antibiotics?
No, it's the same.
Silver particles.
First of all, I'm not aware of any screw that is impregnated with antibiotics. And second, I fear this is the same problem with giving local antibiotics like vancomycin in every case, or giving IV antibiotics that are specific to low-grade bacteria. It has not shown to make any difference, not only in spine surgery, by the way, but also in hip and knee surgery. This is one of the problems that you have because you don't eradicate that with that. And I'm a strong believer in the fact that the number one driving factor, if you develop a biofilm or not, is intrinsic to yourself. That means to the host, to the patient. You can cope with it with this type of bacteria, then you don't have a problem. If you have any not well defined until now intrinsic property that you can't cope with them, then you have the problem. And this has something to do with the immune system. If you look at patients who have Parkinson's, they have a very high rate of low-grade infections. For example, if you do their spinal implants, but also if you do their DBS implant. And the reason is most probably that they, from a certain stage of their disease on, they can't cope with their commensals like you and I can do. If you look at their skin, they have this greasy skin. That also means that you can't cope with these bacteria. For example, the case I showed you, the guy who had just a simple lumbar disc surgery, developed this destruction then at the level L23, the second case that I showed you.
Yeah.
He's a colleague. He's a colleague. He has a dermatological problem related to commensals because he can't cope with it. So he wasn't aware of that before, other than he had, dirty skin. But after that, he did an elaborate workup in his department of dermatology, blah, blah, blah. And then they found out that he has a problem, but still it's not well defined.
Okay. So the other question for when you think of antibiotic impregnated implants is they have a certain half-life until the antibiotic is gone again from the implant. And then the question arises whether this is really an implantation problem, this infection in, or this is a hematogenous problem. And I think we see very late infections after implantation, which brings you towards the more hematogenic or hematogenous infections that you can have it just by any bacteria in your bloodstream.
Yeah. The other patient I showed you with the annular closure device, that was actually 5 years after implantation, which is a very, very long time. But by the way, this happens in these annular devices also at the typical time frame of 10 to 12 months. And these holes that you see in the vertebral bodies, by the way, were one of the problems where the FDA were reluctant to give clearance to that device, because this is seen, be it also asymptomatically, in a very, very high proportion of patients in that trial that tried to do the market, the CME market.
Okay, one more question is regarding Halo. So Hole was a good point. How if you have a patient who had an infection, has really big holes, and you need to put implants again because it's not sufficiently stable, how do you handle it in cases where a size 10 screw or your maximum diameter screw is still too small? Well, the question is, do you use bone cement? I would add, do you use a sponges bone from somewhere else, or how would you re-instrument such patients?
There's no really a good rule for that. I wouldn't use bone cement. That means PMMA or things like that. I don't think that's a good idea in a setting like that, because you can never be sure that all bacteria are eradicated, and then you do another foreign material. So if you want to instrument the vertebral body, which has huge holes in it, if you need to do that, then you have to use cancelled bone to fill that up, and the biggest screw that you have. But to be honest, I'm trying to avoid that. So if the holes are too big and I do a CT scan, let's say 3 months after explantation, I still see this and no sign of anything else, I just usually I extend the instrumentation levels. And then in those, let's say L4 is completely, and I can't instrument L4, I would try to have a sufficient anterior support there with an OLIF or an ALIF cage.
Okay. I have no more question. I have a final question. As you go for 2-stage revisions, it would be very helpful to have any imaging modality showing prior to explantation of a large construct, this is infected or this is not infected. Do you have any experience with PET imaging? If you have a very strong nuclear medicine department in Munich, did they look for it? As far as I know, that there's only very, very sparse literature data showing a few cases where it seemed to work, or is there any other modality you could use for doing an non-surgical and non-communication identification of an infected lucid screw?
Well, what you could do is, I mean, what I don't have experiences with PET in these instances because I haven't done so in any of the cases. What you learn if you have experience and if you look, then if you remember the first case that I showed you where I have these fluid, for example, and if you look at T2 images, I know there's always an artifact which is a problem. At T2 images of these patients, then very often you see this fluid around. I don't even know if it's fluid or if it's the biofilm or whatever, but usually it's a mixture of both. So sometimes you could just aspirate that and then do a culture on that for 14 days. So you know beforehand. I haven't done so very often. What I do is, like in the case that I showed you, if I have a high index of suspicion in the guy who had this lumbar disc surgery and the one who did not have any surgery at all, I just took biopsies from that, CT guided, have cultures for 14 days. And that is probably a good thing to do. If someone comes back with a screw loosening, usually you also have a lot of pain, which actually goes immediately away if you take out the screws. So I do that anyway.
Okay, so no more questions. Bernhard, thanks a lot for this very helpful
thank you.
Presentation and a very helpful discussion. I think we covered many important points. Thank you for all participants for joining us. We had over 80 participants for this webinar. Our next webinar will be again first Wednesday in March, which is March 1st. And you will get informed about who's going to present and what we're going to talk about. Thank you for this day and enjoy your evening. Bye-bye.
Bye.